In this video, we're looking at a question that sounds simple, but is clinically very important. Can mirtazapine, a medication most people know as an antidepressant, actually help people reduce methamphetamine use? In this video, I'll take you through the results of a recent phase 3 trial that tried to answer this exact question. Could mirtazapine reduce methamphetamine use compared with placebo? But I'll go a bit further, because the real question isn't just, does it work? The better question is, what kind of effect is it? I'm Dr. Sanil Rege, consultant psychiatrist. I work in addiction psychiatry, and I've treated many patients with meth addiction. It's one of the most challenging forms of addiction to address, not simply because of the drug itself, but because of the way it can reshape rewards, salience, impulse control, emotional regulation, and the individual's identity over time. We'll come back to why that makes treatment so difficult later in the video. So in this video, I want to explain what this study found, why mirtazapine is being studied for methamphetamine use disorder, and what the placebo difference actually means, and why medication is only one part of the story. This video is educational, it is not personalized medical advice. So, the study we're discussing looked at mirtazapine 30 milligrams daily for 12 weeks in adults with moderate to severe methamphetamine use disorder. The main result was this. People taking mirtazapine reduced their meth use by about 7 days out of 28. People taking placebo reduced their use by about 4.8 days out of 28. So the difference attributable to mirtazapine was about 2.2 fewer days of meth use per month compared with placebo. Now clearly, that's not a miracle, but it's also not useless. And this is where it becomes important to put these numbers into clinical context, because when people hear mirtazapine helps meth recovery, they may imagine a medication that switches off craving, and the person stops using methamphetamine from the following day. But that's not what this study shows. What it suggests is more modest, but still important. Mirtazapine may create a small but meaningful biological shift that helps some people reduce use when embedded in broader treatment. So let's use a framework to approach this question. Let's start off with mirtazapine's mechanism, then link it to clinical relevance, then understand who may benefit, and finally, let's address the cautions. Because the biggest story is not mirtazapine. The biggest story is how addiction recovery actually happens in practice. So first, let's start off with the question, why mirtazapine? What's the mechanism? Why do they think about mirtazapine in meth addiction? Mirtazapine is an antidepressant, and we know it also has anti-anxiety properties. It's often also prescribed off-label to address insomnia. Mirtazapine has several pharmacological actions. It blocks central alpha-2 adrenergic receptors, which can increase noradrenergic and serotonergic signaling. It blocks 5-HT2A, 5-HT2C, and 5-HT3 serotonin receptors. It also blocks histamine H1 receptors, which is why it can cause sedation and increased appetite. I've covered mirtazapine in more detail in this video here. Importantly, blocking 5-HT2A receptors provides an anti-anxiety effect. It also promotes slow-wave sleep, the deep sleep. 5-HT3 antagonism provides anti-nausea effects. Now, why would that matter in methamphetamine use disorder? Methamphetamine strongly affects dopaminergic, noradrenergic, and serotonergic systems. Chronic methamphetamine use alters reward learning, salience attribution, which means what the brain tags as important. It affects habit formation, stress regulation, sleep, and impulse control. Importantly, the person does not just like meth. The brain begins to predict meth as a solution, which means the individual moves from liking to wanting to seeking it. Meth becomes a solution to fatigue, emotional pain, shame, boredom, sexual inhibition, social disconnection. What initially begins as pleasure or reward can become compulsion. This is known as the ventral-to-dorsal shift in addiction. I've covered this in more detail in the Neuroscience of Addiction in this video here. Essentially what happens here is that the individual moves from voluntary control voluntary choices of goal-directed actions to habitual operation. They're driven by cues and stimuli, essentially operating on an automatic mode. Early on, drug use is often more ventral striatal, reward, novelty, pleasure, and wanting. Over time, it becomes more dorsal striatal, cue-driven behavior. In simple terms, the person's operating on autopilot, driven by cues. So the person may no longer be using it because it feels amazing. They may be using it because the brain has learned, this is what I do when this state appears. That state may be loneliness, agitation, sexual craving, exhaustion, etc. I've covered the impact of meth use in a few videos here. So where does mirtazapine fit? Mirtazapine may reduce some of the reinforcing effects of methamphetamine through serotonergic modulation, particularly 5-HT2A and 5-HT2C pathways. It may help with sleep and anxiety through histamine antagonism. It may support monoamine regulation in a system that's been dysregulated by chronic stimulant exposure. This does not mean mirtazapine fixes dopamine. That is too simplistic. What it does is it slightly changes the internal conditions under which methamphetamine use becomes more or less likely. So what did the study show? The study showed a statistically significant reduction. Note, statistically significant, not necessarily clinically significant. The clinical result was reduction in methamphetamine use days compared with placebo. What's important here is the placebo group also improved. 4.8 days per month reduction. That's important because addiction trials often show meaningful placebo or treatment context effects. That tells us that the treatment effect is not just about medication. It goes beyond that. You see, entering a trial is not neutral. You're being assessed, monitored, you're seeing clinicians, you're asked about your use, you're thinking about change. You may feel observed, you may feel hopeful, you may expect change. What's known as expectancy bias. You may have contact with people who care whether you show up. That alone can change behavior. That does not mean placebo response is fake. It's essentially the psychosocial domain of treatment, therapeutic attention. So the mirtazapine group improved more than placebo by around 2.2 fewer days of use per 28 days. The appropriate interpretation here is mirtazapine may add benefit on top of the treatment context. And that takes us to the really important aspect of treatment context. You see, addiction is more than the drug or, in treatment, the medication. I've discussed in a previous video why addiction neuroscience is more than simply choosing the right medication. We know in methamphetamine addiction, lisdexamfetamine has been considered as a treatment as well. But we don't have a magic bullet that treats methamphetamine use from a medication perspective, because addiction is not just about drug exposure. It is drug exposure plus what the brain's learned. Drug exposure plus relief. Drug exposure plus identity, plus environment, plus memory, plus human attachment systems. This is why we need to address addiction as a multi-pronged approach. Consider a biopsychosocial approach. So let me break that down for you succinctly. Let's start off with the biological targets. Biologically, we can think about multiple systems that are involved. The dopaminergic system, which is central to salience, wanting, motivation, reward prediction, and reinforcement. It's essentially what tags the brain's attention and also changes behavior. Methamphetamine strongly amplifies dopamine signaling. So what happens is cues become really powerful. Cues drive behavior. A place, a person, a text message, a time of day, a sexual context. These are not just reminders. They become triggers with a motivational force. And in chronic methamphetamine use, this motivational force becomes so powerful that the individual starts operating on autopilot. Then there is the serotonergic system. Serotonin is involved in impulse regulation, satiety, emotional flexibility, and certain aspects of reward processing. Then the opioid system. This is often overlooked because it's thought of as involved with heroin or pain medication. But opioids are deeply involved in social bonding, warmth, attachment, comfort, and relief. Humans regulate each other through opioid systems. A touch, for example, releases endogenous opioids. This is why loneliness can physically hurt. This is why social rejection can feel unbearable. This is why some people use substances not to get high, but to feel held by something. Then we have glutamatergic systems. Glutamate is central to learning, memory, and synaptic plasticity. There's a concept known as long-term potentiation where the brain strengthens association. In addiction, cues and rituals become deeply learned. Glutamate's involved in this process. So the brain does not just remember the drug, it remembers the entire sequence. The anticipation, the preparation, the relief, the social environment, the sexual context, the after effect. So if we want to help the individual towards recovery, we need to move beyond just suppressing symptoms. What we have to look at is to try to weaken the old predictions and build new ones. And that's hard. It takes repetition and it takes time. To the psychological realm. Psychologically, change requires more than just insight. Insight's useful, but insight often fails when the body is operating on a cue-triggered state, on autopilot, because the prefrontal cortex is no longer involved in decision-making. The individual is operating from the dorsal striatal pathway, the habit mode. The person may know methamphetamine is destroying their life and relationships. But when the state arrives through cues, agitation or shame or craving, despair, the brain searches for the most reliable solution it knows. After all, the brain is about prediction. What it craves most, or requires most, or needs most is predictability. If it knows a predictable solution, that's what it's going to seek out. So psychological work has to ask, what state comes before the use? What is meth use really solving? And this is where we enter the deeper psychodynamic layer. Addiction can be conceptualized as a solution to an underlying problem. A solution to loneliness, shame, inadequacy, low self-esteem, trauma, anger, a self that feels empty. This does not mean that the addiction is chosen. It simply means that the brain has found the most effective form of emotional regulation. The substance offers greater predictability than other objects, including people, in this individual's environment. Finally, social targets. Socially, addiction is often maintained by objects. And by objects, I do not just mean physical items. Objects can be conceptualized as people, places, rituals, communities, phones, messages, rooms, sexual networks, emotional substitutes. So a drug can become an object. A dealer can become an object. A text message or a phone becomes an object. A using partner becomes an object. These objects regulate the person. They act as effective tools of emotional regulation because they provide escape, stimulation, or identity or belonging. So optimum recovery often requires object substitution, a substitution in a deep regulatory sense. Building gradual attachments towards new objects takes time and the building of trust. Because what we're asking the individual to move towards is belonging without the drug, identity without the drug, sex without the drug. And this is often frightening. This is why social treatment is not just an optional extra. For many people, it forms the foundation of treatment. Coming back to mirtazapine, let's think about who might benefit from mirtazapine in this context. Possibly people with methamphetamine use disorder where sleep disturbance, anxiety, appetite disruption, depressive symptoms, agitation, or heightened arousal states are parts of the cycle. The trial, however, did not show a broad significant effect on depression or insomnia overall compared with placebo. So we can't conclusively say that mirtazapine helps meth withdrawal or meth use because it helps sleep. That may be true for some people, but the mechanism may be broader. And what do we need to be cautious about? In this study, drowsiness was more common with mirtazapine. Second, weight gain was also more common. For some people, increased appetite may be helpful after stimulant-related weight loss. For others, it can become a reason why they stop the medication. Third, discontinuation was higher than placebo. Now, this matters in real-world addiction treatment because adherence is crucial. Another important clinical aspect is that because methamphetamine use disorder can be comorbid with other conditions such as bipolar affective disorder or methamphetamine-induced psychosis, when these conditions are present, it becomes important to treat these conditions as bipolar affective illness or treating psychosis with antipsychotic medication. Here, mirtazapine is unlikely to help. In bipolar disorder, it can increase the risk of manic episodes. So always consider a broad clinical evaluation. So the message here isn't ask your doctor for mirtazapine in the context of methamphetamine dependence. The message is this may be one option worth discussing with your doctor within a wider treatment plan. So if there's one thing to take from this video, it's this. Mirtazapine may help reduce methamphetamine use for some people, but it should not be understood as a standalone. The deeper task in addiction recovery is to change the predictions the brain has built around the drug. The prediction that meth is the answer. The prediction that life without it is unbearable. The prediction that no other object, no other person, no other future can regulate the system. Medication can help shift the biology, but recovery requires new learning, repeated learning, embodied learning, and relational learning. This is where psychiatry becomes more than prescribing. It's important that we formulate the picture. You're watching the Dr. Rege channel, and I'm Dr. Sanil Rege. If you like this clinically nuanced neuroscience-informed approach, like the video, subscribe to our channel, and consider joining as a member for early access, where I can address comments as a priority. And for clinicians who want deeper structured learning, including courses such as the Neuroscience of Addiction, have a look at the Academy by Psych. We go deeper into addiction, psychopharmacology, formulation, the neuroscience of psychiatric practice, and lots more. I look forward to seeing you in the next video. Until then, stay curious. Bye-bye.